So, hello guys, very good evening. And what to say? Finally, we are on the eve of the D-Day. I think it's a hi Saurabh. I think it's a very auspicious occasion. We all have been waiting for this day from not only the days, not only the weeks, not only the months, but from years because it's a 1.5 year now. The paper was to take place before in January and then it goes on, postponing. So I can understand the fear, anxiety, and apprehension that you people must be having, but I would say that this is the day that you have been waiting for. So, when you are waiting for some day or something to happen for a very long time, you should not be sad or anxious when it is, it's going. I think it's a when it's going to take place, we should all be very happy, go in a very, very positive attitude, motivated because we have done more than we could do because of the ample time and trust me, we have done everything that is required, be it, clinical case questions or the high yield questions, the image based questions, the important topics, high yield topics. So you are already prepared and we all feel that we are forgetting. So that is a human nature, a tendency that everybody has. Don't worry about that everybody must be having, and I think some amount of fear is important because that stimulates our sympathetic system, that increases our activities, the power to work. So that should be there, being all positive vibes around. Go, and I am sure that you will all come up with flying colors, and we will be sitting face to face, and I'll be talking to you about your success stories, right? So, on the verge of it, we are doing some more questions so that you can answer here and you can realize that whatever I'm saying is true, you all know, and we can just quickly discuss some of the important questions, right? Uh, Hi everyone. Hi Sumaya, Priyanshu, Dr. Joe. Hi Pooja. Hi Chinnam. Why are you so scared and don't feel embarrassing about it? First of all, don't think about that you will not be able to do because you will be able to. And if you fear from failure, always remember that winner is a person who actually tried one more time. So before that winning, he was also a failure. So if he starts thinking that I could not do, he would never be a winner. So you have to win in your mind first. हाय सात्विक। यस, मैंने आज भी साथ नहीं छोड़ा क्योंकि साथ तो मुझे कभी छोड़ना ही नहीं होता है। आई वॉन्ट टू बी विद यू पीपल ऑलवेज, है ना। बाद में भी आई बी टॉकिंग अबाउट योर सक्सेस स्टोरीज और उसके बाद ऑल ऑफ यू ऑल दोज ऑफ यू विल कम इन द ऑफ्थल्मोलॉजी PG residency, will be again talking about it. So as I always say, I am there for you and I'll always be there for you. So I would say thank you so much for all your patience and interaction. I feel very happy when you people interact with me, right? So let's get started. Give me a thumbs up, come on, if you all are ready. Should I start? अच्छा, कुछ लोग तो आंसर भी दे रहे हैं। गुड दिलप्रीत, है ना। उनका डोंट वेस्ट टाइम, राइट। ठीक है, सो रैपिड फायर राउंड करें। लेट्स सी। All of the following options are the ways to increase the amount of the drug absorption of an eye drop, except, so which of the following are the things that are increasing the absorption of the drug? Number one is prior administration of a topical anesthetic. Does it improve the absorption? First of all, tell me, is it true or false? We will go true or false wise. something like this. What do you feel if I give a prior administration of a topical anesthetic? Is it going to increase the absorption? Yes. So this is a true statement. Why it is true? Because topical anesthetic actually disrupts. Yes, very good. आदित्य, डोंट वरी अबाउट टैकीकार्डिया, चिल मारो, इजी। जो भी हम कर सकते थे टू द बेस्ट ऑफ आवर एफर्ट्स वो हमने कर लिया है, अब परफॉर्म करने की बारी है। एंड व्हेनेवर वी हैव टू परफॉर्म वी हैव टू कूल डाउन। तो जितना एक्साइटमेंट एंड हाइपर होना था, जितना स्ट्रेस लेना था, जितनी एंजाइटी लेनी थी, वो हम सब ले चुके हैं। वी आर ऑल थ्रू इट। नाउ यू हैव टू परफॉर्म वेल, डोंट वरी, एंड you will perform well, I know. So topical anesthetic will cause disruption of the corneal epithelium. Because it is causing the disruption of the corneal epithelium, so it will increase the absorption. Number 2. What about the statement number B? Nasolacrimal duct occlusion. If you are occluding this nasolacrimal duct, will it increase the absorption? Tell me true or false, true or false, true or false. See, we do not know what pattern we will be getting tomorrow, but we are ready for all types of pattern. You can get all except question, you can get all question. And eye closure after the drop administration and increased hydrophilicity of the drug. So tell me about true and false. I do not know your name. Hi, sorry for spamming in your chat. Don't worry. 6 years, 10 years does not matter. The matter is how you perform on your D-Day, how you perform on your final day. So I want everybody to chill out. Be in your senses, because you know when you're worried, you are anxious, you are not able to give your best shot, and I want everybody of you to give your best shot, not my best shot, not his best shot, not her best shot, your best shot. And your best shot you will give only when you are mentally free, relax होके जाओ, ठीक है? पहला हो गया। नंबर 2, nasolacrimal duct obstruction. It is again true क्यों है? Because it is actually decreasing the drainage of the drug, pump drainage of the drug. This will decrease the drainage of the drug, so you are having more one. Then eye closure. This you must have seen whenever you people ask me about the eye drops. I say please sit for 5 minutes closing your eyes. Also we have to increase the duration between the eye drops. Whenever you are giving the 2 eye drops, it's good that you increase the duration between the 2. If you remember last year, there was a question in AIMS. June 2020 paper mein, there was a question. I had discussed in the recall also. Nurse had a eye ointment and a eye drop. So which one of the following she should give earlier? What should be the order? There should be any gap or not. So always remember that whenever we have increased viscosity, that is again important. If I have increased viscosity, then that also increases the absorption. So if I have ointment form will also have more viscosity. More viscosity means more absorption. Plus it is sticky also. Ointment is sticky. So it's always better that we give this ointment HS. HS means at the night time. But they had not given any such option of giving the ointment at the night time. So what we did, we have to give first the eye drop. Therefore, first give the eye drop, then give the eye ointment, and then there was a gap of, if there is an option, give a gap also. But normally we give the drops in the day and ointments in the night, so that throughout the night the ointment can give a good amount of absorption. Finally, we have got option number D, increasing the hydrophilicity. Now this is actually wrong. What we require is actually the lipid solubility, not the hydrophilicity. Lipid solubility we require. So more is the lipid solubility, more will be the corneal penetration. more is the lipid solubility, more is the corneal penetration. That is why what is not increasing the absorption of the eye drop is the hydrophilicity. It is actually the lipid solubility, occluding the nasolacrimal duct will decrease the drainage of the drug. Yes, correct. So are you clear with this question? Because nowadays they are asking you the questions related to the practical aspect also. So I think this is a good question related to those points which we are using. They want to see whether you have ever visited the ward or not, whether you have seen how to give the ointment, how to give the drop, all those practical aspects. So clear है question number 1. Question number 2 देखते हैं. Which retinal layer is accounting for the petalloid cystic appearance of the cystoid macular edema? Yes. So who will give this answer? Which retinal layer is responsible for petalloid appearance in the cystoid macular edema? We all know that when we do the FFA, in cases of the cystoid macular edema, we get the typical flower petal appearance. So why do we get this flower petal appearance? Now you can answer this question theoretically also, because everybody knows which layers are involved in cystoid macular edema. So who will tell me which layers are involved in the cystoid macular edema? Whenever we have the cystoid macular edema, we have actually, cystoid means we have got cyst-like spaces. So we have got cyst-like spaces forming in the macula due to the collection of the fluid. Are you giving the answer for question number 2, or which layer you are giving? Give the answer for question number 2 now. ठीक है? So which layers are involved here? Do you remember the open? We have outer plexiform and the inner nuclear layer. And which one is more important? This is outer plexiform layer, which is called as Henle's layer. It is the outer plexiform layer or the Henle's layer which is more responsible for the cystoid macular edema. So what will be the answer? So from the theory also you can answer that the answer is the outer plexiform layer, which is also called as the Henle's layer. This is again an important thing. It is called as the Henle's layer. ठीक है? Now if you look at the structure, see, first of all we will see the structure of the retinal fibers. Suppose this is the retina here, and we have got this horizontal raphe. So on the nasal side we will have a optic disc, and therefore temporal side will be the macula. So what will be the fibers like on the nasal side? They are always the radiating fibers. These fibers are the superior and inferior radiating, radiating fibers, while on the temporal side we have the arc-like fibers. And because these fibers are arc-like, they are also called as the arcuate fibers, like this. And then we have got this. These are called as the superior and inferior arcuate fibers, right? Now this is your macular area, this is the optic disc. So in the center of this we will have the papillomacular bundle. Again an important thing, this is called as papillomacular bundle. Papilla matlab optic disc, macula, and so these fibers which are joining the optic disc and macula are the straight fibers. Okay? Now go to this. So on the nasal side we have this optic disc, and on the temporal side we will have this macula. That is why, can you appreciate these arc-like fibers here? These are your arc-like fibers on the temporal side, arcuate fibers. So they are leading to this, this one, Petalloid pattern in cases of the outer plexiform layer. In the outer plexiform layer. So is this question clear to everyone? Outer plexiform and inner nuclear. Yes. Anybody having any doubt in this? Baki, all the retinal layers we have already discussed. If you have any doubt, please tell me. Otherwise, we will be going to the other question. एक बहुत interesting question है. See this. They are saying that there is a 50-year-old diabetic woman. ठीक है, 50-year-old diabetic woman है and she is presenting with the progressive blurring of vision. So we are thinking in terms of diabetic retinopathy. Now a similar episode has also occurred in the left eye. So there is a bilateral diabetic retinopathy. She has not having any previous laser photocoagulation. Which initial therapy would be most appropriate for this patient? Can you tell me what is the diagnosis? What type of retinopathy or what are the changes that you can see in this FFA? This is fundus fluorescein angiography. So first question is, what are these? What are these you can see? What are these? And then second, first of all, what are these changes? You have to tell me. What are these changes? And second, you have to tell me which vein you are using for this. Which vein we are using for this dye. Then the third thing is, what is the treatment? Treatment for the PDR and clinically significant macular edema. So we will be discussing this question in three forms. What are the changes? So first of all, who will tell me what are the changes? Dilpreet is saying A, pars plana vitrectomy. Where do we use the pars plana vitrectomy? कब करते हैं in cases of diabetic retinopathy? Let me keep this as a 4. Where to do the pars plana vitrectomy? So vitreous hemorrhage. This is vitreous hemorrhage. See, what you can see is this pooling. This is the pooling of the dye. ठीक है ना? Collection of the dye या फिर pooling of the dye है. Now dye is present in the blood. So basically this is actually whole of your blood collections. Blood means we have neovascularization. And neovascularization means PDR. So this is the FFA of PDR. फिर से सुनो, we have this whitish hyperfluorescent areas. That means we have pooling of the dye. Dye will be flowing through the blood. So we have collection of the blood and this blood is actually getting collected. So that means there is a lot of neovascularization. And what is this? Neovascularization, right? Microaneurysms. We have very little, yes. These small ones, these. I am highlighting them. These are your micro aneurysms. Hemorrhages are very little. ठीक है? Antecubital vein, exactly. We give it through the antecubital vein. Laser photocoagulation. Yes, Saurabh, very good. So this is actually PDR. अभी क्या है कि when first of all the changes that we are having, I have told you that this is basically the neovascularization, and neovascularization means we are dealing with a case of PDR. ठीक है? दूसरा the vein that we are using for giving this is the antecubital vein. The vein that we are using is the antecubital vein. Now, what is the treatment of PDR? So, treatment of PDR will be your PRP, pan-retinal photocoagulation. I think this is a better term than the laser photocoagulation because in cases of PDR, we have to cover whole of the retina. So, when you cover whole of the retina, it is something like this. Suppose this is the retina, right? And here we have this optic disc. So what we are doing, we are giving small spots. So we are giving the laser spots 500 microns. We are starting from the periphery and we are coming towards the center. Starting from the periphery and going towards the center. What is the size of each spot? Answer this question. Size of each spot. So answer this. Size of the each spot. What is the duration of the each spot? Okay. So when we are giving these, they are creating the blind spots. Now because they are creating the blind spots and we have created whole of the ring, this is called as the ring shape scotoma. So it is also coming under the DD of ring shape scotoma. Now we can give the PRP here, but this patient is also having the clinically significant macular edema. What do you mean by clinically significant macular edema? Another question. Clinically significant means when you are getting them either at the macula, changes are at the macula, or they are within 500 microns from the center of the macula. From the center of the macula. Either they are at the macula or within 500 microns from the center of the macula, along with the increased retinal thickness. Increased retinal thickness, that should be more than 1 disc diameter. What is 1 disc diameter? 1.5 mm, that is 1500 microns. And what was the size of each spot? 500 microns. Duration is 0.1 second. Okay? Size of each spot 500 microns. Duration is 0.1 second. And the distance between the two spots. Distance between two spots. The distance between two spots is also 500 microns. Distance is also 500 microns. So if I am having this also clinically significant macular edema and I am giving PRP, now this can go to the macula and it can cause what? So at the macula actually it can cause the ischemic maculopathy. It can cause a problem of the ischemic maculopathy. That is why, because in this case we have clinically significant macular edema, it is looking to be very near to the macula. What I am going to do, I am going to give PRP along with the grid or the focal treatment for the macula. So as we reach to the macula, we give very, very small laser spots so that we are not causing the ischemia at the macula. So if you look at the options, first is the pars plana vitrectomy. Have you given the answer why we are doing this pars plana vitrectomy? सौरभ 5000 नहीं होता, 500 होता है, 500 microns. It is 500 microns given for a duration of 0.1 second and the distance between the two spots is also 500 microns. Now pars plana vitrectomy we are doing for the tractional retinal detachment. Whenever the patient is developing a complication, then we are doing this pars plana vitrectomy. So this is wrong. Will we do the follow-up visit just after 1 month? क्या PDR के cases में can we afford to leave the patient and do the follow-up after 1 month? No. So you are left with two options. Either you are doing just the PRP or you are doing PRP along with the focal macular treatment. So answer will be here C. Combine PRP with the focal or the grid macular treatment given at the macula so that we can prevent the ischemic maculopathy just at the macula. Are you getting this? Clear hai sabko? Then another important thing is, what are the high risk characteristics in the cases of PDR? Whenever I am having a case of PDR, then there are certain high risk characteristics. So वो बहुत important है because certainly you are going to get 1 or 2 questions from diabetes. So whenever you are having any neovascularization over the fundus, any means any, किसी भी type का neovascularization पे fundus neovascularization है fundus पे, then that is a high risk characteristic. Then second, if it is present within 1 disc diameter of the optic disc, ठीक है? Then if you are having the vitreous hemorrhage and neovascularization is also moderate to severe. Any neovascularization मतलब mild हो सकता है, moderate हो सकता है, severe हो सकता है, within 1 disc diameter हो सकता है, and the vitreous hemorrhage All of these are very, very high risk characteristics in the PDR. And whenever we are having the high risk characteristics in the cases of the PDR, then we are going to give the PRP along with the grid or the focal treatment for the macula. Are you clear? क्योंकि fundus image जरूर आएगी and I think diabetic आनी चाहिए because diabetes is very, very important. So I am having this notion that this could be one of the probables. A similar type of question can come tomorrow. Yes, ठीक है. Next चलते हैं. Yes, question number 4 पे चलते हैं. A copper intraocular foreign body is there. We have a copper intraocular foreign body, and that can cause all except sunflower cataract, KF ring, suppurative endophthalmitis, or irreversible flat ERG. 30 seconds for you people. Give the answer. Copper intraocular foreign body. Till then, I am telling you what is the most common intraocular foreign body. The most common intraocular foreign body is the chisel and hammer. Chisel and hammer. Chisel and hammer means we have got the chips of the iron. The chips of the iron are the most common intraocular foreign body that we get. If I talk about the investigation of choice, right? So for the localization, when it comes to localization for the iron, the MRI is contraindicated. MRI is contraindicated, so best will be the CT scan. While for taking the visual acuity, the best is the ERG. The best for taking the visual acuity is ERG. Are you clear? Thank you, Neil. Thank you so much. I am humbled for your such a good comment. So for the localization, the best is CT scan, and for the visual acuity, what is best is the ERG. Now, I will remind you, because this question again came in AIMS 2019. What are the do's and don'ts? Don'ts, I'll write first because they are more important. Do's and don'ts of the intraocular foreign body. Whenever you are having a penetrating trauma by the intraocular foreign body, what are the things I should not do? So don't touch the eye, don't rub the eye, don't cover the eye, don't wash the eye, and don't remove the foreign body. This don't remove the foreign body actually came in AIMS. If you remember, there was a question I showed you where there was an iron nail that was penetrating the cornea, and they say what should not be done. So you should not actually remove. That does not mean that you do not remove the foreign body ever. You do not remove it until you are all set in the OT, because you are converting it into an open wound. So that can cause the infection, that can cause the endophthalmitis, right? You will prolapse could be there, iris prolapse could be there. So that is the reason why we are not removing. Don't touch it, don't rub it unnecessarily, don't cover it. You also have to tell all these things to the patient, because you might not do these things, but patient may do these things, because these are the most tempting things that one likes to do or wants to do. There is an urge to touch it, to cover it, to run it, rub it, because patient is having pain. So you have to be very, very careful. Now, what are the do's? What are the things we should do? We should do the slit lamp examination. You have to do the slit lamp examination. You have to see how much amount of injury has been occurred, what are the organs which are damaged. You have to take the visual acuity. I told you the best is the ERG. Take the visual acuity as accurately as possible. Then give the antibiotics. Very, very important. You should also give the antibiotics, because there is always a risk of endophthalmitis. So you cannot take a chance. Then if you have to cover it, like it should not be done ideally, but agar fir bhi hame karna hi pad raha hai because we have to refer it, so then you have to cover with the moist cotton. You have to be very, very gentle, okay? You don't have to press it too hard. And if you have to wash it for any reason, normally we don't prefer washing it, then you have to use the lukewarm water. So these are the do's and don'ts. Do's and don'ts of the intraocular foreign body, most common intraocular foreign body, investigation of choice for the localization. B scan, Satish, B scan किसका आंसर दिया? ठीक है, अब यहाँ पर क्या है, यहाँ पर हम बात कर रहे हैं कॉपर की. वी हैव अ कॉपर इंट्राओकुलर फॉरेन बॉडी. So if I have the copper intraocular foreign body, obviously I will have copper deposition. I will have the copper deposition, and copper deposition is called as the chalcosis. ठीक है ना? So once we have this chalcosis, I always tell you that whenever we have intraocular foreign body, we have a risk of endophthalmitis. So that will be your suppurative. That will be the suppurative endophthalmitis. So we have that risk of suppurative endophthalmitis, and copper deposition leads to a kind of a cataract called as a sunflower cataract. What are the other causes of sunflower cataract, by the way? What are the other causes of sunflower cataract? We also get this in the Wilson's disease as well as the penetrating trauma. Wilson's disease as well as in the cases of penetrating trauma. So we are covering all other questions also related to it. और क्या हो सकता है copper deposition से? Something which is not pathognomic of one disease, but yes, it's very famous for one. So we can also have the KF ring. Now if you remember, last year this question came in INI-CT. That this is a pathognomic of Wilson's disease, and that statement was wrong. Yes, so it is actually found in Wilson's disease, but it's not pathognomic because we can get in primary biliary biliary cirrhosis as well as wherever we have the copper deposition. So even here, when we are having this copper deposition, I can get this KF ring that is called as the Kayser-Fleischer ring. Kayser-Fleischer ring. Are you clear with this? So if you look at the question now, so if I have an intraocular foreign body, it can cause all except sunflower cataract can be there, KF ring can be there, endophthalmitis can be there. So even by the diagnosis of exclusion, you know the answer will be irreversible flat ERG. Now why I am getting this? See, this is partly correct. I am getting a flat ERG, but this is actually reversible. It is not irreversible, it is reversible. So the moment you extract the copper intraocular foreign body, it can again be coming in the form of spike. So that is the reason that option number D is correct answer to this question. It is not irreversible, it is reversible flat ERG. So see if you are clear with this question number 4. Can we move to the other ones? Clear here? हाँ, I do not know कि exact question ये आएगा या नहीं आएगा, but I can say that some similar questions will certainly be there because we are expecting a question on fundus image, we are expecting the question on diabetes, we are expecting the questions on the systemic association, so that is there like KF ring है, and trauma पे हमेशा question आता है. Then we are expecting questions on the practical aspect जो कि हमने लिया in the form of a drug also. So we are expecting all these questions, right? Next, एक ये हम बहुत बार कर चुके हैं. We have done a lot of practice on the PARC 3-step test, but I want to give you a final touch even before going tomorrow. So I'll take it again. So tell me, if you know the answer, if you know how to do it. Please tell me. A 32-year-old female is presenting with the insidious onset of diplopia. On alternate covering test, patient has a right hypertropia, worse on right head tilt and the left gaze. Yes, ma'am, hai sabka? Please keep on answering. I do not know whether you are able to get me or not. So please, every one of you start doing it. You already know the PARC's 3-step test. PARC's 3-step test. Very good, Dilpreet. Do this one also now. Patient has a right hypertropia. Now, whenever patient has a right hypertropia, it could be something like this, or it could be left hypo. So, right is getting relative hypertropia. Right का hyper हो सकता है, left का hypo हो सकता है. Right hypertropia और left hypotropia. लेफ्ट का हाइपरट्रोपिया हो सकता है या फिर लेफ्ट का हाइपोट्रोपिया हो सकता है. Now, because I am having right hyper, so there is a palsy of depressor. So we have the depressor palsy here. While left side में it's going into hypo, so I have a elevator palsy. Elevator palsy of the left side. Now, what are the depressors of the right side? Right inferior rectus, right superior oblique. These are the depressors of the right side. What are the elevators of the left side? Left superior rectus and the left inferior oblique. See, you have got all the 4 options which are given in your question. Now, your step number 2. This was your step 1. Step 1 hai ye. The step 2 is it is increasing in the left gaze. Increase in left gaze. ठीक है. Those of you have some confusion, please try to see. This is your step 2. This is your step 2. It is increasing in the left gaze. So do the left gaze here. Here. ठीक है. Left gaze means right eye is looking towards left and left eye is also looking towards left. So right eye will do the adduction and the left eye will do the abduction. Now, do you remember the important dictum? What was the dictum? Maximum elevation and depression. Maximum elevation and depression in the adducted eye. When you have the adducted eye, maximum elevation and depression in adducted eye will be done by the oblique muscles and in the abducted eye. In the abducted eye, it is done by the rectus muscles. By the rectus muscles. So, adducted eye में obliques से होता है. So, adducted eye means the right eye. So, we have to choose the oblique here. While the abducted eye is the left eye. Choose the rectus here. So, you are left with 2 options. या तो हमारे पास हो गया right superior oblique या फिर left inferior rectus. Right? Left superior rectus, sorry, or the left superior rectus. These are the 2 options. Now they are saying that it is increasing in which tilt? Words on the right tilt. So it is like this, it is like this. Now we are having the right tilt. Now when I am tilting my head towards right, क्या होगा? Right eye will go in the opposite side, left eye will also go in the opposite side to maintain a balance. ऐसे होगा. So, right eye is going into intorsion and the left eye is going into extorsion. ठीक है? Superiors are intorters. So, right superior oblique is a good choice, but we know that superiors are intorters and so we require an inferior muscle here. So, this is wrong. Answer will be right superior oblique. Look at the answer. Answer will be your right superior oblique. See if you have understood this. Anybody having any confusion in this? Anybody? Saurabh ne kar liya right superior oblique. Any other person who has a different answer? Any other person who has some different answer? ये बस समझ लो आने वाला है. Anyhow, this will come. So please be very, very careful about this question. If you have any doubt, please ask. Now, let us see this another question. Which of the following is not true of retinoblastoma? Not true. एक तो पहली बात, read the question very carefully. Many a times, out of anxiety, to save time, we miss 1 or 2 words of the question and that lends up into silly mistake and blunder. You are going exactly with the opposite of what is asked. So if you are reading it, which of the following is true of retinoblastoma? And they are asking which is not true. So please don't do this mistake. ठीक है ना? Give seconds, ample seconds to read your question. Very, very important. There is an increased incidence of developing secondary malignant tumors later in the life. So tell me about true or false. Is it true or false? To Aditya. Aditya, there is a similar question which is coming up again. Don't worry. And also tell me in which step you are having a problem. We will do it again. Third step. थर्ड स्टेप में प्रॉब्लम है. थर्ड स्टेप में प्रॉब्लम है. एक बार देखो फिर से. हमारे पास दो मसल्स थे, राइट सुपीरियर ऑब्लिक एंड एक था लेफ्ट सुपीरियर रेक्टस. दिस वी वर देयर आफ्टर द सेकेंड स्टेप. पहले ये देखो, ये क्लियर है. अब वी आर हैविंग दीज आईज. ठीक है. वी आर सेइंग दैट इट इज increasing in the right head tilt. It is increasing in the right head tilt. मतलब right में tilt कर दिया head. तो जब हम right में head tilt करेंगे, something like this, we are tilting the head. ऐसे. So eyes are going in the opposite direction. क्यों? क्योंकि balance maintain करना है. If eyes are also going in the same direction, there will be no balance. So if my head is going like this, I will go towards left side. So eyes will go towards left. Like this and this. ठीक है. So what is happening in this? So right eye किस में जा रही है? Intorsion में जा रही है. And left eye किस में जा रही है? Extorsion में. अपने ऊपर करके देखो एक बार. Right head tilt करके देखो. Right eye जाएगी nose की तरफ, intorsion. And left eye जाएगी ear की तरफ, extorsion. And we know superiors are in tortoise. Sin मतलब superiors are in tortoise. इसका मतलब इंटॉर्जन जिसमें हो रहा है उसमें हमें चाहिए सुपीरियर मसल, एंड एक्सटॉर्जन जिसमें हो रहा है उसमें हमें चाहिए इंफीरियर मसल. सो वी रिक्वायर अ इंफीरियर मसल बट देयर इज अ सुपीरियर मसल हियर. तो ये कट हो गया. तो कौन सा सही हो गया? राइट सुपीरियर ऑब्लिक इज द करेक्ट आंसर. अभी देखो आदित्य, और कौन था? Raj Mathangi and Aditya, see if you have understood this now. See if you have understood this. अभी भी कोई प्रॉब्लम है तो बताओ, फिर से हम करेंगे. नेक्स्ट क्वेश्चन, विच ऑफ द फॉलोइंग इज नॉट ट्रू ऑफ रेटिनोब्लास्टोमा. तो पहले वाले का ट्रू और फॉल्स बताना है. विल यू गेट सम इंक्रीज इंसिडेंस ऑफ डेवलपिंग secondary malignant tumors? Will you get some? Two mutations in the chromosome number 13 are required to develop retinoblastoma. True or false? Retinoblastoma may present. Please tell me A true, B true. इस तरह से बताओगे. Otherwise, I won't get to know which statement you are saying true or false. Retinoblastoma may present with orbital cellulitis, strabismus, or hyphema. True or false? Rees-Ellsworth classification of retinoblastoma provides prognostic information about patient survival. True or false? So there are 4 questions now. Thank you, Agya. Have you understood? So who will tell me? So let's start with one by one. सबसे पहले, which there is an increased incidence of developing secondary malignant tumors in the life. So this is a true statement. We can have most common primary tumor which is associated with the retinoblastoma. What is that tumor? That is the pinealoblastoma, and that is called as trilateral. That kind of a tumor is called as trilateral retinoblastoma. Then we can also have most common secondary tumor. We can also have most common secondary tumor associated with the retinoblastoma. What do you mean by the secondary tumor? Means after the treatment of retinoblastoma, when the patient is disease free, you have already given the treatment of retinoblastoma, then also the patient can have a tumor that is your osteosarcoma. Then also we can have a tumor that is your osteosarcoma. So we can have secondary tumors in the form of pinealoblastoma and in the form of osteosarcoma. Are you clear with option number 1? ठीक है? Very good. बी का बताओगे, 2 mutations in the chromosome number 13 are required to develop retinoblastoma. Is it true or false? So this is again a true statement. We have got the Knudsen two-hit hypothesis. Knudsen two-hit hypothesis is there. So we require 2 hits. So we require 2 mutations. ठीक है? Retinoblastoma may present with orbital cellulitis, strabismus or hyphema. This is true or false? What is the most common presentation? If you look at the most common presentation, then this is your leukocoria. Leukocoria is the first most common presentation. Then the second is the squint. Squint is the second most common presentation. What kind of squint? Come on, answer this question. What is the kind of squint? Then third most common presentation is the glaucoma. This is the third most common presentation. Now what you have to tell me is the type of squint. Then you have to tell me about the type of RD. What type of RD we can get here? Then you have to tell me about the age of diagnosis. What is the most common age of diagnosis? Then another question, most common route. This question came recently, route of spread. What is the most common route of spread in the retinoblastoma? Yes. Tell me all these questions. What is the type of squint that you get in retinoblastoma? Quickly, we have got number of questions. 1. Number 2, what kind of RD you will get here? Number 3, what is the most common age of diagnosis? Number 4, what is the most common route of spread? The type of squint. The type of squint that we are getting is the convergent squint. Mostly we are getting the convergent squint. Mostly we are getting convergent kind of squint. What is the type of RD? What is the type of RD that we are getting? The type of RD that we are getting is ERD, exudative RD. The age of diagnosis is less than 3 years. The most common age of diagnosis is less than 3 years, especially 1.5 years. 1.5 years. And the most common route of spread. Most common route of spread is the optic nerve. So these are again very, very important questions. You can have unilateral retinoblastoma. You can have bilateral retinoblastoma. No, it's not the tractional RD, Dilpreet. It's not the tractional RD. It is the exudative RD. ERD. Exudative, not tractional. In cases of the diabetes, PDR may you are getting the tractional RD. Here you are getting the exudative RD. And most common route of spread is the optic nerve. No, it's not tractional. Exudative RD is more common in cases of tumors. ठीक है? And childhood नहीं लिखना होगा. You have to tell me the age. Less than 3 years. Specifically speaking, always remember that 1.5-year-old child coming with the leukocoria. 1.5-year-old child coming with the leukocoria. Along with this, if I am having the calcification, then you are amply sure that you are dealing with a case of retinoblastoma, because no other case of leukocoria presents with the calcification. Now, what is the DD of leukocoria? The most common is the congenital cataract. We can have the congenital cataract, where then we can have the Coats disease, retinopathy of prematurity, we can have PHPV can be there, right? Retinoblastoma is there. Then we have the toxocara and ophthalmitis. Toxocara and ophthalmitis is also there. So all of them are the DDs. Anybody who can tell me what is the investigation of choice for the retinoblastoma? What is the investigation of choice for the retinoblastoma? Anybody? Yes. Investigation of choice क्या होगा? Like what are the investigations that we can do In a case of retinoblastoma, I can do the B scan ultrasound. We can do the CT scan, MRI orbit. We can do, then we can do the plasma LDH levels also. Plasma LDH levels. But what is the investigation of choice? Anybody? Yes. Investigation of choice का होगा. B scan पे भी you can see the foci of calcification. You can see the involvement. You can see the retinal detachment. Uh, on the CT scan, it's very good for the calcification, of course. Plasma LDH levels जो होते हैं, that is for prognostic value, not the diagnostic value. And MRI is there. So answer to this question is yes. Very good, Raghunath. It is the MRI because calcification you have to see. तो calcification we can see on ultrasound or MRI. CT scan से नहीं करते हैं because we do not want to give the radiation exposure to the small children. That is why CT scan is not the investigation of the choice. ठीक है? Saurabh, no, CT scan is not the investigation of choice because we do not want to give the radiation exposure to the child. Radiation exposure देने से metastasis भी हो सकती है. There can be increment in the size of the tumor. That is why. All those of you are typing CT scan, please listen. It's not CT scan. It's MRI. See, I'm happy that I'm able to rectify you, and I'm not so happy uh, because you know, if you are doing this mistake, maybe you are missing. So please rectify your mistake. So it's not the CT scan, it's the MRI, right? Now coming to the next question, a 10-year-old boy is referred for the evaluation of diminution of vision. Look at the age of the child. And examination is revealing the visual acuity of 20 by 20 in the right eye, 20 by 40 in the left eye. So one eye is having the normal vision 20 by 20, left eye में 20 by 40 है, which is also correctable with glasses. ठीक है, examination of the left fundus is important because it is showing a yellow orange cystic macular lesion. So we are having a problem in the macula. Father is also reporting several other members have been suffering from mild to moderate deterioration of vision. So that means it is autosomal dominant condition of the macula where you are having the yellow orange cystic lesion. And which one of the following be most helpful in establishing the diagnosis? And the most important thing of this question is the image. Now, can you tell me what is this? First of all, tell me what is this sign? What is the name of the disease? And then what is the best investigation? Because we have to tell about the best investigation. Best investigation for this disease. So can you tell me the sign? Can you tell me the sign? What is the sign actually? Anybody? ये तो जरूर बताना पड़ेगा. We have discussed it 100 of times. Fundus images में है. And again a bumper question that can come tomorrow. ये क्या है? See this. This is your optic disc. ठीक है ना? ये optic disc हो गया. And here we have the macula. So what we are having in the macula is this orange cystic lesion. What is the name of this lesion? Anybody? What is the name of this lesion? Bangladesh. Thank you so much. Love from Bangladesh. Thank you. So this is what? जल्दी बताओ सौरभ कहाँ है? सौरभ आदित्य? Yes. Guys, is it fine now? There was some network problem actually. Please let me know the audio video. Are you able to get my audio video now? Yes है अभी. Yes. Now, actually आज तूफान आया हुआ है. कल नीट पीजी का पेपर है ना, so it's all तूफानी weather outside. So I was telling you that we have got this egg yolk appearance in cases of best vitelliform macular dystrophy. So what is happening? It's a vitelliform macular dystrophy. Why? Because we have this egg yolk appearance. Best because it was given by the Frederick D. Best. It was given by Frederick D. Best vitelliform because we are having a egg yolk appearance. Okay? It is a autosomal dominant condition and it is the second most common macular dystrophy. It is not the most common macular dystrophy. It is the second most common macular dystrophy. Now, because you are having something here in the RPE layer of the macula, you are having the deposition of the lipofuscin. We are having the deposition of lipofuscin in the RPE layer, and it is golden brown color, that is giving it a egg yolk appearance. Now we all know that if you compare the EOG and the ERG, which one is better? So it is the EOG, which is considered to be the best disease for the best vitelliform macular dystrophy. Why? Because in the ERG we have got three waves, the A wave, the B wave and the C wave. Right. Now A wave is coming from rods and cones, B wave is coming from Mueller cells, and it shows the activity of bipolar cells, while C wave is showing the RPE activity. Now who will tell me that which wave will be normal and which wave will be abnormal? Which will be normal? Yes, thank you. So which wave will be normal in cases of Best disease and which will be abnormal? Now if you look at this A wave, this will be normal because we do not have any problem with the rods and cones. So this will be normal. What about the Mueller cells and the bipolar cells? So these are also intact. So this wave is also normal. The only problem that we are having is with the RPE, and that too only in the macula. In the RPE of the macula, I have the deposition, so this is reduced. So only problem that we are having is a reduced C wave. Jabki EOG is entirely abnormal. ERG mein only we have reduced C wave. Therefore, best test for the best disease. Best test for the best disease will be the EOG. Are you clear? What is the most common macular dystrophy? Most common का भी नाम बता देते हैं. What is the most common one? So the most common is the Stargardt disease. Yes. Most common is the Stargardt disease. And what is the appearance that you are going to get here? Like in best vitelliform macular dystrophy, we are going to get the egg yolk appearance. In cases of the Stargardt disease, what is the appearance that we get? We get the beaten bronze appearance. There we get the beaten bronze appearance. Are you clear? This is the most common and it is autosomal recessive. Jabki second most common is the best vitelliform, that is autosomal dominant. Clear hai? Okay. Now, one last question. Patient seeks ophthalmological evaluation because his friend is saying that his eyes don't look right, something is wrong. And they are saying, सबसे ज़्यादा important line जो है वो more anisocoria was present in dark than in the light. Again, there was a question related to this last year in AIMS. So that means the eyes were not looking right. उसमें क्या हो रहा था? There was a anisocoria. What is the definition of anisocoria? When you are having a difference in the pupillary size. If you are having the difference in the pupillary size more than 0.4, then we call it as anisocoria. And they are saying it's more in the dark. All of the following are true statements except. So let us see. Number one is your true and false. करके देखते हैं. Neither pupil should constrict to pilocarpine. True or false? Bronze beetle, yes. True or false? Number two, responsible lesion should be interrupting the neural impulse as the neuron synapse in the ciliary ganglion. True or false? The presence of the right abduction deficit would localize the lesion to the right cavernous sinus. True or false? And the right pupil will dilate poorly after cocaine at 10% installation. True or false? So give me true, false, whatever it is, according to ABCD. Meanwhile, I am telling you this flow chart, which is very, very important for anisocoria. You have to see whether it is increasing in the dark, anisocoria, or it is increasing in the light. Anisocoria increasing in the dark or anisocoria increasing in the light. So if it is increasing in the dark, that means it fails to dilate. How to interpret? इसका मतलब क्या है? The normal pupil is not dilating because an abnormal pupil is not dilating, because when we go into the dark, normal will dilate. Now, if the abnormal is not dilating, anisocoria will increase. Fails to dilate means there is a problem with the dilator pupillae muscle. And dilator pupillae muscle has a sympathetic supply. So, therefore, what is the diagnosis? The diagnosis will be Horner syndrome. Because in the Horner syndrome, what we have is a oculosympathetic palsy. We have the oculosympathetic palsy. There is a paralysis of the sympathetic supply. So dilator pupillae not able to act, and therefore it is increasing in dark. So the diagnosis of our question is Horner syndrome. अभी अगर दूसरा होता तो let us see this also. When increasing in the light. If it is increasing in the light, then see the shape of pupil. Then see the shape of the pupil. Okay. Then we can have two conditions. It is normal or it is abnormal. If the shape of the pupil is abnormal, then we can have trauma. If it is normal, then we give 0.125% pilocarpine. This is actually called as the dilute pilocarpine, and this question came last year INI-CET 2020. Okay? Dilute pilocarpine. Now, dilute pilocarpine gives the constriction. It gives the constriction only in the cases of the AD's tonic pupil, because we have got the denervation sensitivity. So, if Horner syndrome person is given 0.1% pilocarpine, it won't constrict. So, that is the right statement. Now, suppose you are not getting any constriction, then you have to give 1% pilocarpine. And again, see the constriction. Now, see, is it plus or minus? If it is constricting, that means it's a third nerve palsy. If it is still not constricting, then it is a pharmacological blockade. Again, this flow chart will help you like anything, whether it is a Horner syndrome, AD's tonic pupil, third nerve palsy, pharmacological blockade, or the sphincteric damage trauma. All the things can be diagnosed from there. Now, go back to the question. This is a case of the Horner syndrome where anisocoria is actually increasing. Very good. Yes, all my blessings are with you, with all of you who are going to give the examination tomorrow, Yuvraj. All the very best. And that is the reason we are doing the session, so that you do not feel alien. Don't feel nervous. Go in the flow. Okay, na? So, it is a case of Horner syndrome. Now, because it is a case of the Horner syndrome, therefore, it will not constrict to pilocarpine, because that does there in cases of AD's tonic people. So, this is true. Responsible lesion could be interrupting the neural impulses. This is true, as the neural synapse in the ciliary ganglion. So, this is false. They do not synapse. They only pass through the ciliary ganglion. The presence of a right abduction deficit would localize the lesion to the right cavernous sinus. This is again a true statement. Because if you look at the cavernous sinus, through the center of the cavernous sinus, we have the sixth nerve and the internal carotid artery. So whichever side cavernous sinus, same side sixth nerve, and through the lateral wall, we have got third nerve, fourth nerve, and the first and second division of the fifth nerve. तो same side का हो गया, true है ये. The right pupil will dilate poorly after cocaine 10%. So yes, whenever we have this Horner syndrome, you give the cocaine, it will not able to dilate, because what is happening, cocaine is actually preventing, it is inhibiting the reuptake of norepinephrine, and Horner pupil will not have norepinephrine because there is a sympathetic palsy. So cocaine will not be able to dilate. So this is also true. So answer to this question will be the responsible lesion could be interrupting the neural impulse as the neuron synapse in the ciliary ganglion, because they are just passing, they are not synapsing. So we are done with the last minute clinical case scenarios for the NEET PG 2021, and once again I would say that I would like to shower all our blessings to you. Please don't have a self-doubt, don't be anxious, take a good sleep, go to bed early today, take a deep breath, take the name of any person, your parents, your God, any guru, or anybody whom you feel you owe your hard work to, whatever you feel, who gives you happiness, whom you feel are your well-wishers, so that you are tension free, anxiety free, and give your paper very well tomorrow. We have done ample practice, you know everything now. Now you have to just recall, and only a relaxed mind can help you recall the things. So once again, all the very best, guys, for tomorrow, and happy ophthalmology. Please do very well. Keep all the instructions in your mind. Read the question carefully. First look up at all the 4 options.